Hi, everyone. I'm Samira Daswani, the host of the podcast, The Patient from Hell. Today, I have a very special guest who we have been trying to get on this podcast, I think, since we started this podcast. I have been fangirling this woman for many years now. I am thrilled to have Dr. Fumiko Chino on our episode. Dr. Chino, welcome to our podcast.
Thank you. I'm happy to be here.
All right, so I'm going to start with not oncology, not cancer, not any of that stuff, but we're going to start with fashion and style because you are, by a long shot, the most fashionable person I've met. Where does it come from? How do you shop? Give us some sneak peeks, please.
I feel you asked me this question. I looked at myself and I was like, oh, I'm not like, I need to tune it up for these, the ones that have video. Thank you, though. I normally have bright colored glasses. I have like a big, large statement necklace. I'm like low key Fridays right now. No, thank you. What I realized is that, like, there's so much joy in fashion, and there's a limited amount of joy in the world, and I just want to promote more joy. So, I'm a big fan of bright colors, bold patterns. It's actually one of the things that even my patients like consistently comment on the fact that they can't wait to see what I'm wearing and what kind of glasses I'm going to wear. And that actually really, really encourages me. It's not great for my pocketbook, I'm not going to lie, but I'm from the Midwest. Girl loves a bargain. So I'm on Poshmark, I'm on the Real Real, I'm on eBay. I got, my designers I like and what size I'm in. So I'm buying on a discount, and I only buy glasses now on like those crazy online glasses stores where you can buy a pair of glasses for $7.99. So um,
Which ones? Sorry, you have to tell me this. My dad loves glasses. Like, he loves them. Like, he buys them in the dozens. And he's the only other person I know who kind of uses glasses in the way you do, right? Which is, I think it is like intentionally matching the outfit. In fact, sometimes it's the statement, right? Anyways, you have to tell me where so I can block it out.
yeah, so I swear I'm not a stock owner in any in anything, to be honest. Very bad with my money. But my most recent glasses have been from a company called Zlol. And what happened during the pandemic is that I had so many interactions, like in this triangle that we're currently interacting with, that I realized that these like big bold glasses were going to make a big difference in terms of just having a personality, because I'm not able to be as warm and in person as I would be, in a normal patient interaction. So I ended up getting kind of bigger and bigger glasses. So I started the pandemic with 5 pairs of glasses, which is already too many glasses. And I ended the pandemic with 13 pairs of glasses.
Wow.
Big fan. We had to use our healthcare savings for something, right? We weren't going to the dentist. So.
Oh, it's funny. I'm surprised you only have 14. I was expecting.
It's enough. I really do. Whenever I travel for like conferences, I pack my dresses and I pack my necklaces and I pack my glasses. And I usually bring 5 or 6 pairs of glasses for 5 or 6 days. I like to have some options. You don't want to clash. And so when you're wearing like a bright colored pattern, you usually wear like calmer glasses. But so
I really don't. Horrible. This is my regular outfit. You're seeing.
Well, I mean, it's the Audrey Hepburn, everything looks better in black. I don't know if I have much black in my wardrobe at this point, actually. So,
I have a funny story for you. So I used to live in New York, and two roommates of mine decided to go through my closet one day, and I think it was like 95% black, and they got really, really upset. So
I
they
mean,
had
that is a classic New York thing, though. Like, if you are on the streets of New York, it's black, 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 black. I mean, it is a universal. It's just, I got to walk my wild way. So, I grew up a half Japanese kid in Indiana. I was already standing out at 6 foot from the time I was in fourth grade. So, I decided to embrace it at some point.
That's remarkable. Okay, I love it. How did you end up in oncology from growing up in Indiana?
Yeah, no. Well, I didn't ever plan on being a doctor for sure. I went to, you know, I went to the university that was free, that was farthest away from home. So I went to Houston, Texas, for my undergraduate, and I got a bachelor's of fine arts in studio photography / digital imaging. And so I spent years in the art scene. I was an art director of an anime company. And so I never really planned on being a physician at all, much less an oncologist. I really did get pulled into it kicking and screaming. In an alternate timeline, a sliding doors, a phenomenon, I would be just happily doing something else right now that would probably be very arts focused.
Huh. Out of curiosity, what would you be doing? It's an anime company.
Yeah, I don't know. Honestly, I think I'd be managing an arts nonprofit right now.
Mhm.
I think that's where my alternate skill set may lie. And I would probably still be writing grants, but they would be for putting on performances or opening up like community outreach, that sort of thing, and not anything to do with cancer.
Uh,
But here I am.
Dr. Chino, did you know I studied art history?
No, that's cool.
My undergrad was in art history.
Yeah,
So,
I mean, it's funny how you end up. I have to say, this background in arts has really, it served me pretty well as an oncologist. I think it gives me a different perspective, which is for good or for ill. I know a lot less about the Krebs cycle, and I know a lot more about communication, which is honestly most of art is about communication, or that's how I'm going to spin it for this podcast.
there we go. We're
Um,
gonna leave it to that.
so yeah, it's been a wild ride, but I was never, I was just happily, anime, Sailor Moon, we were working on launching our anime magazine when my fiance was diagnosed with cancer, and that's really kind of what pivoted my world into a
Mm.
medical society, concept, all engulfing catastrophe.
Hmm. Are you comfortable talking about what happened then?
Sure. I mean, I feel like it's part of my origin story, unfortunately. But yeah, I always want to start with like just like I was an independent person before cancer. I'm an independent person after cancer. I feel like so many patients and survivors and caregivers and even providers, again, they get defined by being like a cancer patient or cancer survivor, and we were all whole ass human beings outside of cancer. But anyway, my fiance at the time, then husband, was diagnosed with a sort of fast growing cancer, very common for the AYA population, or, like anyone below the age of 40, kind of face a lot of barriers to diagnosis, tend to have more aggressive cancers. And, we kind of struggled through the healthcare system. We had a lot of costs related to his care, and made these difficult decisions that a lot of young people have to make about what to do with your career, what sacrifices you're willing to make, how do I pay for this? How do I like keep the lights on? What am I willing to give up, really? For a period of time, we even moved in with my parents. That was fun. And eventually we ended up in Michigan, which is where he died in the hospital. And we had sort of just moved there. And so then I sort of just stubbornly stuck it out there for another year and a half with like very little support system,
Mm.
before moving back to Houston and getting started with the process of thinking about medical school and kind of like what I was doing with my life.
Um, can I ask you something here? So here you are in Michigan, trying to decide how your life changes. Why did you go into medicine versus, I don't know, start a nonprofit, impact the community in a different way?
Yeah, I think stupidly thought that I had something to contribute, based on my experiences, based on my passion to help people, based on what I perceived as the gaps between care that's intended and the care that's delivered. And so it was really just ego. Um, that brought me into medicine. I felt like I could help maybe change the story a little bit. I felt charged. How about that?
Yeah.
I felt like there were some discrete things that happened along my husband's course that probably could have been better. So, um, stupidly, I thought I was the one to do it.
I don't know how stupid that is. I think it's pretty cool.
Mm-hmm.
For example, I'm super grateful that you're a doc on the other side.
Well, I mean, I think similar things happen with kind of your own life, right? Which is like you get a huge derailment related to cancer, and then you kind of you're at the end of it, although there's no end of it. There is no end of it. You're at the end of active treatment. I'll put that in quotes, and then you're like, what? How do I put the pieces back together to form something that assembles an idea of a future?
Yes.
And I think some people have a harsher time of it. And it's like sort of like, how hard did you crush the cookie? you know? And it can be related to, yeah, toxicities of treatment, the intensity of treatment. But also, like we all come to different, we're not all given the same size cookie to begin with. So how you try to kind of put it back together is, this analogy is getting very frayed.
I was trying. I was like, vase gonna work. Cookie. I'm like, how do you put a cookie back together? I was like, doc, this is gonna be a hard one for me to summarize.
No. Yeah. I spin out narratives all the time for my patients. I'm trying to give them examples. And I'm like, it's like car insurance. You don't get into an accident and then buy car insurance. This is how I describe radiation all the time.
Huh?
Um,
No. You'll have to explain that to me. I'm like, what? No. I didn't follow.
oh, I always say that, so when someone's had surgeries for something like breast cancer and
Yeah.
the tumor's been removed, what I'm doing is treating single cancer cells that may or may not be there. And the problem is that I don't know if they're there. And so it really is like an insurance policy. And you don't buy an insurance policy after getting into an accident. You get it now and you hope you never need it. And that is the unsatisfying result of cancer treatment, after chemotherapy, after radiation. The only way we know it works is if you live the rest of your life and you die of something else.
Yeah, it's true. Huh.
And so it's it's weirdly unsatisfying. It's also like incredibly helpful, which is like, I'm going to take credit for you're 100 years old and you're living your best life. When I'm 100, I'm going to be like, with my cane, like stealing groceries or whatever. But when I die in my sleep at 100, I consider that a successful life. We all got to go sometime, but yeah, that's the future I'm planning for all my patients and for myself.
I like it.
We're all going to be stealing groceries at 100.
There were two things you said that I wanted to sort of underscore, and then if we have time, come back to.
Sure.
The first was kind of the motivation of like, the care that is intended is not the care that is delivered. And I think that is such a powerful phrase, and I think it's such a well encapsulates the reality of cancer treatment.
Yeah.
And honestly, like the work we do as well, I think it's exactly that, right? There's this gap.
Yeah.
I'd love for you to talk a little bit more about that.
Yeah, absolutely. I think despite our best intentions, despite all of the privilege that we have, I deliver care in the United States, one of, if not the wealthiest countries, certainly a country of privilege where we have every bell and whistle, and yet not everyone can access those bells and whistles. Not everyone has the capacity for receiving the highest quality of care. And even when I am able to offer the best, every bell and whistle, how it actually is, delivered to the person and kind of their capacity to receive it, can be quite variable, right? And again, it's communication is a part of it, right? But access, affordability, these are all like large barriers.
Yeah.
One of my most well-lauded studies is on parking costs, which is quite frankly like a really stupid thing to study. Like, why would parking be a barrier to anyone? It's parking. But it really hit a nerve because patients are like, I hate it. It doesn't even matter if you're a billionaire. Billionaires hate paying for parking too. But what's truly insulting is that people who actually can't get the care that they really need in the facility that would probably serve them best because of a silly barrier like parking.
Dr. Chino, I fully agree. The person I met more than just about anybody else in the 18 months of treatment was the parking attendant. He and I
You
became
form
a
those great
buddy.
relationships, right?
Yeah, you do. He was a buddy of mine. He
Yeah.
literally, like, I would come in, if he wasn't there, someone else was there, I would actually be really sad because he would talk to me every single time I pulled up my car and every time I left. And then 9 out of 10 times he would waive the parking fee for me. And it was just the sweetest, nicest thing because when you have to pay the whatever $5 and I'm privileged that I can afford to pay the $5 and I can walk, but to have a patient park, pay, and then have to like somehow figure out how to get out of the car, make their way through all of the rigmarole to get to the right spot inside the cancer treatment center was just, I used to watch that and it used to like break my heart, and he would make that easier.
Yeah, it's actually it is shocking how much it's the full companion of people that make a huge difference for your care. And I think, providers, doctors, we think, oh, it's my voice that matters. And it's not like it doesn't, but I think we underestimate how the full package makes a difference. The parking attendant, it's the person who checks you in, it's the person who takes your vital signs. It's the person who draws your labs, and it's the entire experience that can make a huge difference. And it's funny, like there's some amount of corporate speak that goes on here. I found out recently that we call it a warm welcome at MSK. We want a warm welcome for everyone, which sounds like, again, it's a little corporate-y, but I love that concept, which is that we are trying to envelop people in warmth,
Hmm.
because that heated blanket, that, whatever, like person offering you a coffee, it makes a big difference. Or alternatively, the sour note can ruin your whole day.
I fully relate. Honestly, this company wouldn't be, and like we have a company, we wouldn't be doing anything had it not been there was a survivor. Actually, I think it was a mom of a patient going through it who sat in hand knit hats for all the patients going through chemo. And this woman, I don't know who she is, she left it at the reception. And I remember it was just like, it was COVID, all of the nonprofits had shut down, all of the sort of like supportive care space had shut down. Getting stuff was hard. This was like early COVID, like first month of lockdown. And I had just lost my hair, couldn't get a wig because everything had shut down, right? So like, and I had to go into work and it was cold. Like the thing they don't tell you is it like when you don't have hair, it is cold. You get cold a lot. Anyway, so I walked into the system and the receptionist hands me a hat. And I was so happy. I was like, oh my God, here is this hand knit hat that I didn't even know I needed, but has become basically a safety blanket for the next 18 months of care. That somebody, I've never met this person, uh, completely transformed the full experience for me. Anyway, yes, all of this to say that I fully agree with the statement you just made.
It's an act of kindness that, man, I mean, this is true outside of oncology, outside of critical illness. I mean, like, just being kind is just like such a huge thing. I mean, I have to continually remind myself, even for people who I consider unkind, that, like, okay, like, I don't know what's happening in their life. Probably something else is, driving this. I have to give some compassion to them, you know, to try to, so where I'm looking for, I don't know, put good vibes out into the universe. Hopefully good vibes will return, like if you're going to be kind of munchy crunchy about it. But man, like just selfless acts of kindness. Like, man, you made me cry with that hat story. But
I'm
I love it. And again, that person, I'm just going to be totally gendered and say that it's a woman. That that person who knit you that cap, um, it could be that no one else cared about the caps, but it made a difference to you. So,
Dr. Chino, it's why I made the planner. I'm not joking. I am not joking. I fully, I normally don't say this because it's such a long, I normally don't go into this level of detail. It's just we're talking about it. It was why I made the planner.
mhm,
Because here was this person who had never met me, who somehow knew that that was a thing I needed at that point in time.
mhm.
And it
I
wasn't a
mean, that's
nonprofit. It wasn't this big thing. It was just this moment of like, like anticipated need of someone going through it. And I was like, oh my God, this person can do such, like, made such a big difference in my life. If I could do something using my skills, like, I can't knit to save my life. Like, that just, I just don't think that would be how I give back. But, like, I can, like, make something that has value and give it back. And, like, honestly, that was the moment. I was like, oh my God, that is exactly why I need to do this. And just, anyway, so.
that's the foundation of my career. This concept that maybe we could make care or treatment or the journey, I'm again air quotes, the journey of cancer, if we could just make it a little easier. Like, and I usually for mentally, 1% easier is my goal. 1% easier. But the thing is that if you make care 1% easier for a million people, you've made a profound difference in the world. And I think classically, at least as cancer doctors were constantly like, oh, I want to find the cure for cancer or, whatever. But I just want to cure more cancers that are curable, or I want to, provide more comfort to people who have, who are suffering. I want to, provide, I want to envelop people in warmth when they might have been a little cold. And that's really that's the whole concept that drives the kind of research that I do and the care that I provide. I'm just like, I want to help a lot, but barring helping a lot, I want to help a little, you know.
Do you know that's a mission of our company?
Help a little.
No, it's just make the cancer experience just a little easier.
Yeah. Yeah.
That's the
Yeah.
mission. Because I
I
think we
did not know that.
yeah, I didn't think we did, which is why I said it, and I was like, "Huh, this is so." Like, and for what it's worth, for all the people listening, and this was not planted at all. I can promise you that. But it really is. I think we're surrounded by a lot of companies trying to do what I would put in the bucket of like moonshot, right? Like,
Mhm.
let's transform oncology. Let's yes, all of that is needed. I'm fully supportive, but honestly, it's the small things that are needed first. It's the small stuff.
It's the
It's the small
hat.
stuff first.
It's the hat. It's the parking. It's the warm blanket. It's the, it's the map.
Yeah,
You know.
that was also not planted.
Hmm. Yeah.
Yeah, no,
It's
exactly.
the packet of saltines. Those
Yeah,
saltines. Oh, they are clutch.
I will say I am a little. I'm at the point where saltines equal trauma for me, so I am not at saltines equal happiness right now. But at some point in my life, that may transform into happiness again, but not there yet.
You can come full circle on it. I have I'm sending you wishes that you
Thank
can
you.
reclaim saltines.
Thank you.
I can't, based on my own PTSD, I can't watch the movie Dreamgirls. I
Mm,
cannot hear This American Life,
mm.
and I can't see the Oscars.
Hmm.
Those are my triggers.
I can relate. I have my list. I have my radiation playlist cannot ever be played again. No song on the radiation playlist is ever being played again. There is a list. Yeah.
God bless America.
Wow. Normally, when we talk about science and research, it's very easy for me to be very, like, here are my clinical questions for you, doc. This one.
Oh, I'm happy to answer those. I mean, honestly, as a radiation oncologist, what I do is often, I mean, I'm basically aiming invisible light into people to kill cancer cells that may or may not be there. I mean, it seems like very woo woo. So I'm happy to explain that. But in reality, I'm also happy to talk about fashion.
I have never heard a radiation oncologist call their work woo-woo. I appreciate it.
It seems like magic, right? I'm
Yes.
trying to break cellular DNA, and I'm breaking all of the DNA. It's just that your own cells repair their DNA. It seems bananas, but it works. And it works, you know, enough times to save lives. But I'm always really honest with my patients, and I'm just like, the problem is that I know I'm like of 5 women, I'm going to save potentially one person. The other 4 may or may not needed it. It's really just it's to save that one person. And I don't know if that person is you, but I don't want to take the chance that it's like you wouldn't play Russian roulette with one live bullet, when that bullet's cancer. So I want you to take the treatment. But in reality, if you walk out the door right now, you'll probably be okay.
Huh.
I mean, probably is not, like that's the problem with large numbers, right? Statistically, it's probably not going to happen to you,
Yeah.
but I can't tell you that it won't. It's like a really good thing or a really bad thing. And that's what's really frustrating. Numbers are imperfect, you know?
The reason you see me pause on that is I think I fall into the patient camp that really goes deep on numbers.
Mm,
And I really struggled with the decision you're talking about. I had a
mm-hmm,
phenomenal rat arm. She's amazing. And we had a long discussion on local recurrence, distant recurrence. We went like deep into the rabbit hole of like stats. And eventually, honestly, it came down to, do I trust her?
yeah.
Because it is what you're describing. Like
Yeah.
radiation does feel like this, because you don't even feel the, if well, I shouldn't say that. I definitely had really bad reactions to radiation. Very bad. Had to stop. Bad reactions. Like grade 3 level symptoms, bad. But it does, you don't feel it in the way you feel chemo, right? Like chemo is like, I'm gonna punch you in the face. You're gonna get knocked out.
Mm-hmm.
Radiation is like, well, I'm gonna boil you in water very slowly. Very slowly. You won't even, you will think it's a sauna. You will love it. And then it's gonna come.
Yeah.
Right? So it's just
Yeah.
very different. Like, anyway.
I mean, I always say it's different experiences. So people come to me after, for example, 4 months of chemo, and they're like, well, I got through chemo, so I'm ready to go. And I was just like, well, most people do easier with radiation than they do with chemo, but there's occasionally people that do way worse with radiation. And I can't tell you that that won't happen to you, but most people do okay. I say okay, reasonably well is the other thing I'll say. I say at the end, you're not going to want any more. I can guarantee you that. No one signs up for bonus rounds of radiation. And even during treatment, when people are like, I'm doing great. And I was just like, you are. I'm going to warn you over the next week that these things are probably going to get a little worse, but it's okay. We're going to, one foot in front of the other. But yeah, it seems it's all about proportional risk, and again, this kind of new phrase in medicine called shared decision making, which is that I think if you're fully informed, like these are the risks of my treatment, these are the benefits, this is kind of the recovery period, it can make, a big difference in terms of people feeling comfortable that it's the right decision for them. And that concept of kind of decision regret, like I did this thing, I didn't really want to do it. And now I kind of like, have all these side effects. I don't think it was the right thing for me. Like that is just the worst.
Yeah.
And our treatments don't always work, and some people have really bad reactions to them. I've had people lose all of their skin, and it's not common, but it can happen. And so I tell that to every person. I was like, it could happen to you, and that
Yeah.
stinks.
Oh, it
Apparently, it happened to you.
happened. It happened.
Yeah, I mean, and it's just so disruptive to your life. I mean, outside of the daily treatments, like that's obviously disruptive, but like, being in pain or being uncomfortable or not being able to sleep well, sleep is truly underappreciated in oncology. It's just, it's insult to injury.
Yeah. I have a hilarious story actually about the moment in time we're talking about, because my tumor was in my right armpit, and so I had radiation in the whole breast, but also in the armpit, and it was like I'm forgetting what it was, like focus radiation, like specific rays focused in that area. So I had the like all my skin came off, and like everything that was my armpit, so I couldn't put my arm down. And the hilarious part of this whole thing is me deciding this is my decision. My family's like, we should go to Joshua Tree over like one of the long weekends. COVID-19, So we drive to Joshua Tree, I have family in LA, except I can't put my arm down. So my arm is above my head the entire ride. I got to a point where I couldn't keep a t-shirt on, so I was like in a bra only. I probably shouldn't be saying this on a podcast, but not exactly pretty. The funnier part of this whole thing is that was when, so I was working at a COVID-19 medical diagnostic company at the time, and we got FDA approval for our device the same week that this was happening. And I was part of the launch team, and I had to like sit and edit all of our like press releases and all the content that had to go out and the instruction material, but I couldn't type because I couldn't put my arm down. So I got very used to using voice AI. Voice AI became a really good friend of mine during radiation, and I have to enable voice AI. It got me through that week. It was highly entertaining. My family looks back being like, you are a nutcase, woman, completely nuts. But we'll ignore that part of it. But, it gets pretty rough. Like, I was not ready for that, to say
Well,
the
we
least.
do what we do to have some normalcy, to have a job, to go on vacation to Joshua Tree, even if it's like we're the insane woman wearing a bra, with their arm up, right? Because like it's like to not taken the trip, or to not like, have a job, like you're just fully embracing being a cancer patient at that point. Like it defines who you are, and you're obviously not, you know it's actually really funny because when people tell me like, well, can I work, should I work, and I'm like, in my opinion you should, because it helps give you a schedule. Like if you can take the time off and you can afford it and you want to, yes, absolutely, but you should at least do something with your day, because I think otherwise, number one, your mind goes to dark places, so we're not built to just sit around the house. But unless we're independently wealthy, which I'm not, and most people aren't, we're used to having accountability. We have to, we're doing this. This is, we got to plan for this. Like that's our personalities. That's our hustle economy, right? And to suddenly be in this sort of like, rudderless sea, where you can only think about cancer all day, is like not necessarily great for you either. I mean, everyone's different. So definitely people have luxuriated in their like, time off, but it's not really vacation.
No, not vacation. Not the kind you want to go on anyway.
Yeah. I mean, it's funny though, because like classically you're like, oh, I wish I could take time off, but I have to work. And I'm just like, in some ways it's actually better for some people, because again, it just like you have something else, you have other shit to do.
Yeah.
I'm sorry, I can't be sick right now. I got other shit to do.
Yeah.
Like I can't I can't feel sorry for myself. I got other shit to do, like I can't, not that you shouldn't, also indulge in that sometimes.
No, it's totally true. On that note, I am going to talk to you about research, because that was one of our themes for the podcast, and I'm reminding myself that I will not forget again that we should talk about this, like I did in my prep email to you. Okay, so I'm guessing you read the study. This is a PCORI-funded study. I'm going to just quickly summarize the study, and then I'd love your thoughts on it.
Sure.
Unfiltered thoughts. Okay, so quick summary, and you can correct if I'm getting the summary wrong too. By the way, if I'm interpreting the results wrong, please do correct me. But the way I read it is essentially many types of breast cancer, we have triple negative breast cancer, HER2 positive breast cancer, hormone positive breast cancer, just as a sort of gross approximation of three subtypes. For women, mostly, sometimes men, but women mostly, with triple negative breast cancer or HER2 positive breast cancer, stage 2 to 3, in that range, they are more likely to benefit, not, I shouldn't say that, they are likely to benefit from active surveillance, i.e. imaging, because asymptomatic imaging is associated with a lower risk of death versus waiting for your symptoms to show up and then go get tested. Is that a fair?
I think we need to provide more context,
All right.
but sure. I don't think that's exactly what the study shows. You're kind of leaping ahead from a. So I think this is the problem with research, right?
I'm ready.
And we saw this during COVID, right? We saw the sausage being made. People were like, the research shows this. And then other people were like, the research does not show that. And, people are like, wait, it's research. How could it be wrong? And I think that there are just many different types of research and kind of what we consider the gold standard, like the best type of research, wasn't being done during the early COVID pandemic. And this research also does not represent like kind of the gold standard. So it's retrospective, meaning that they went back and they looked at all of these charts of patients who got imaging for either asymptomatic surveillance, meaning, again, just routine scans, versus we're not getting routine scans. And I think it's interesting the population that they focused on, which is, stage 2, stage 3 patients with breast cancer. So stage 1, I think everyone agrees, shouldn't be getting asymptomatic surveillance. Too low risk.
Should not be getting.
Should not be getting. No, stage 1, yeah, absolutely. Your chance of catching something that has nothing to do with cancer, but then will lead to a diagnostic cascade that will then eventually like hurt that person is much higher than the chance that you're going to like find something that's actually going to make a difference for them. Stage 4 cancer, everyone agrees. You should be getting imaging, not surveillance. They're like, they need imaging to make sure that their treatments are still working and that they're not having, new problems, etc. It's kind of the people in the middle, right? And the current guidelines are that you should not get any imaging unless there's a problem, which is what I explain to my patients all the time when I, say, okay, we're done with treatment. And they're going to say, okay, when is my next scan? And I'm going to say, never, hopefully. Yeah, I mean, they're going to get mammograms images of the breast, but of whole body scans, I say hopefully never, because I would only be imaging you if you have a problem. But it does highlight the fact that there are definitely people who are not, quote unquote, following guidelines. So there were people getting asymptomatic scans in this group of people. And those, that's even though there are guidelines to say you shouldn't, there's people who do it. Typically for people who are getting guidelines against scans, or getting scans against guidelines. Sorry, this is like a tongue twister. There are people I'm worried about. Like there are people I'm worried about. There's a reason why I'm getting that scan, even though you have no problems. And so it's someone, for example, who I treated as a stage 2 or stage 3, but they had this weird little bone thing. And like, I treated them for a cure, but I'm just like, I want to keep an eye on that bone thing. It's probably nothing, but I don't trust it. So we're just going to continue scanning you to track that. Or like, there was this lymph node. It was over here. Technically, I treated it, but I didn't think it was involved. But, I just want to make sure it's not doing anything funny in the long run. So I would say that probably those patients were a little different, even though on paper they look the same. But what the study found is that those people who have kind of more high risk histologies, the triple negative patients, the patients with HER2 positive cancers, they did seem to benefit from those scans. The hormone positive patients didn't seem to benefit from any asymptomatic scans, which is the bulk of patients with breast cancer. So it does kind of point to this idea that, let's just say you had stage 3 breast cancer, you had a lot of lymph nodes involved, you were treated for cure, you're no evidence of disease. You had triple negative breast cancer. I really, like it kind of does make sense that like you're saying I'm only going to get a mammogram once a year for the rest of my life. That seems bananas. I'm
Right.
like, yeah, okay. I kind of see it. Like maybe we should be, ordering more frequent scans on you. So it is like proof of evidence of that. But then the next step is then to confirm these findings, which is that you do the trial. You don't go back, look through time. You actually say, these are the populations we're studying. Um, let's order scans for these patients, do standard of care. Standard of care in
Yeah.
this case would be no scans, unless there's a problem, and actually see if this
Mm.
makes a difference in terms of their outcomes,
Mm.
right? Because otherwise, you're just like there's so like it's kind of apples and oranges, right? You're like looking back on what is essentially two different patient cohorts.
Yeah.
They look the same when you're like doing a chart dive, but there was a reason why this person got a scan and this person didn't get a
Yes.
scan. Does that
Okay.
make sense?
It does. I have a few questions for you. So the
Go for
first
it.
is just a clarification, because I think when we are saying scan, at least I think we need to differentiate that versus your annual mammo, right? Because a mammo is
Mhm.
also a scan in quotes, right? So can you just differentiate that for us?
Sure. And one of the great things about this study is that it looked at sort of a more modern cohort, meaning like a group of people kind of in the modern era, because scans have really changed. So it used to be scans when we talked about surveillance, were like a chest x-ray and an ultrasound. Like that is like the most basic imaging that you can
Yeah.
get. We hardly ever do chest x-rays and ultrasounds for anything cancer related nowadays. It's just it's like a low quality imaging, what we call. And then what we're often talking about is kind of full body, like kind of from your chin to your mid thigh
Mhm.
scans, like a CAT scan, I'll call it a CT scan, or a PET scan, which is a CT scan plus a metabolic component, which were kind of things that consume a lot of sugar, light up bright. There's also full body MRIs, which we very rarely use, although apparently there's some people shilling for them on Instagram, that you should be buying them out of pocket, $2,000. And those are separate than what we consider just routine imaging of the breast, which is typically mammogram slash ultrasound slash MRI of the breast. And those are really, we have fairly good data about that in terms of there are some people who, even after a breast cancer diagnosis, are going to benefit from more intense screening, meaning like every 6 months,
Yeah.
or some people really don't benefit from that and they should just go back to annual images, but the images maybe should be a little better.
Mm.
Should certainly be, a 3D mammogram, or even maybe a contrast enhanced mammogram, which is a newer technique. So there's quote unquote image of the primary, which in
Yeah.
the case of breast cancer would be the breast, and then there's kind of like surveillance of the rest of the body.
I see. I see.
Definitely people need imaging of the breast. If you have a breast, you should probably get it imaged. But that is something I actually have to explain to people all the time, which is like, if you've had a mastectomy, there's not a role for a mammogram for you anymore,
Mm.
which is really frustrating for people who were really used to getting mammograms,
Mm.
and sometimes joyful for people who are really used to getting mammograms. But it's a distinction, right? Because I can't tell you how many people like have finished their treatment and they're like, okay, when am I going to get my next scan, doc? And I'm like, it's going to be in 10 months and it's going to be a mammogram. And they're like, I can't believe you're not going to get imaging next month. How do we know that this treatment worked? I was
Yeah.
like, well, as I said, this is insurance.
Yeah.
You really don't want an insurance payout, right?
Yes. 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 I fully relate to that mindset, though. I really struggle with that.
Yeah,
Always
it's
struggle.
hard. I
Especially
mean, I tell people all the time, I would get a mammogram every month if I had evidence that it actually would help you. We would be here every month. But it just leads to anxiety. It just leads to additional money and copays and time. And it doesn't seem to improve outcomes.
with.
As soon as we have a group that it improves outcomes for, we should do that. And as soon as you tell me there's a problem, something funny, I don't know what's going on, but I'm feeling pain here. I'm going to bring you in. I'm going to examine you. And if I can't explain it, that's when you're going for imaging, So,
Yeah.
if for nothing else, just for my and your peace of mind. So I was like, I have a very low threshold that if you have a complaint, and I think understandably people are like, oh, so if I just say I have pain, I'll get the imaging.
I will tell you that low threshold mucked with my head A lot.
Mm.
I'll tell you why, because it's really hard to differentiate good symptoms from bad. There's no good or bad symptom, but like it's hard to differentiate a symptom that qualifies reaching out to my clinician versus not. If I have a headache that goes away in an hour, does that mean I should my health message you? I'm guessing not. But I think it's just that they're going through the gradations there.
Yeah, no, and that I can't tell you how many times I've heard that. And so whenever when people are completing radiation, I have like my little spiel and I'm like, this is how you should take care of your skin. This is when you should call me, blah, blah, blah. And I was like, okay, so for the rest of your life, you're going to have weird things happen to you because we all do. Like all of our bodies are full of white light, like we're all beautiful butterflies. And that means that like something's, whatever, something random's going to happen. You're going to have a pain in your knee or in your back or whatever. And I'm like, so you're constantly like, you're like, my body already betrayed me once. Where is it going to betray me again in the future? Right. So I just want to tell you the things that you should actually be worried about versus the things that you could potentially safely ignore for now. And it's essentially any symptom that's new that gets worse over time. That is what I want to hear about. And I'll give you an example of like, I had back pain last week. I slept in the bed wrong. Who really knows what caused it? I don't care. It went away. That is not something I need to hear about. But back pain that is still there a month later is to the point in which you're taking Tylenol every day. That is not normal. Same thing with a headache. I had a headache. It went away. Don't know what caused it. Maybe sinuses. But I've had a daily headache. That is not normal, right?
Yeah.
And so I think it gives people that reassurance of like, oh my goodness, like not every, cough is cancer in my lungs, right? Because most coughs are allergies. But again, even if it's not allergies and it's like heartburn, something that can cause chronic cough, like you probably shouldn't like ignore that for a month and a half either. So like if you've had a cough for a month and a half, even though it's probably not even cancer, someone should be addressing that. I think it helps to give people kind of guardrails, and like I give people permission to be mad all the time. I give people permission to be mad at me all the time, or to be mad at their friends or family. I was like, they don't know what you're going through. You look totally normal, and I say that in a good way, but you don't feel normal. Like, and again, I know you don't want to look sick, you know, but because you look so great, people don't know.
Yeah.
And they think that you're done with your treatment, for example, and they're like, okay, you're better now, like let's get back to life, and you're still like internally scarred. It's okay to just be like, I need a minute, or I need to ramp up, or I need to have a break. It's okay to snap at people occasionally, not all the time. You'll lose your friends, but it's okay to be a bitch, but just realize that we all have good days and bad days. So I give people permission all the time to be mad.
Dr. Chino, I don't think I've ever met an oncologist who totally gets the patient experience.
Well, I mean, people who've been through treatment, right?
Yeah.
And that's it. It totally informs how you deal with people, So, I mean, I haven't been through cancer treatment myself, but I think just, being along for the ride is bad enough. But I don't know, we're all different. We have different levels of approaching, problems and communication and interpersonal relations and framing things. And no one trains us how to be good communicators, really, So you kind of got to want it. And it's funny. I feel like sometimes we're shifting the medicine towards, patient-centered care and communication. Thank God, right? But I wonder if we're not actually accidentally excluding some like really badass surgeons. Like they're not even getting into medical school, the person who would be that great neurosurgeon, because we've weeded them out. They're too weird. I wonder, I was like, are we accidentally excluding those people? Because I don't really need that person to like hold my hand. I just need them to be super like precise and to know exactly what she's doing in the OR, I don't know.
I think that's a really, really fair point. Actually goes back to our conversation on the experience is everyone and not just your oncologist. right? It's the experience is encompassing all touch points with the system and not just that one appointment. And like I'm with you. Like actually, a mentor of mine actually asked me that. He was like, "You need to choose," because one thing we haven't talked about in this episode, but is I think very true. You have a medical oncologist, you have a radiation oncologist, you have a surgeon, and then you may have a primary care doctor. So just as a patient, you're already intersecting with at least three, maybe four people, if not all of the other kind of like specialty care stuff. So as a patient, you have many people you're touching, right? And at some point, you will have a bond with one of them and not a bond with another one of them. But to your point, the surgeon may be a really good surgeon, and you may just not have gotten to like being buddies with this person. And then how do you grapple with that? And one of my mentors actually told me that. He sat me down and he's like, "Look, you're going to face this. Just remember, they're not there to be your friend." I was like, fair enough.
I feel like we're in a reality show. I'm not here to make friends.
Okay. I was like, yeah, fair enough. Good point. Like, I'm watching the clock, and we, of course, have gone way over. It's
Of
not highly
course.
surprising. So as a wrap up, I'm going to go back all the way to art and fashion.
Okay.
Sorry. I don't get to do that. We have to talk oncology all the time. I don't get to talk about art, and just much nicer. Okay, so if you had to teach all your peers, not just radiation oncology peers, but like all cancer doctors, anything you could about how they could practice medicine differently by learning something from the arts, what would you tell them?
I saw this in your note preps, and I was like, I gotta have something that really kind of ties together. But I think it's just that everyone, when they look at a piece of art or they see a piece of modern dance or they listen to a song, they're gonna take something different away from it slightly. Even all Taylor Swift fans are gonna, have like their own interaction with the song slightly different based on kind of their lived experience and their perspective.
Mm.
So like everyone sees something differently, right? And so, in that capacity, like that communication that you get from, in this case, a piece of art, or like that in between each person, it's like it truly needs to be tailored to that person, because someone's capacity for understanding what you're saying is going to be based on who's in the room with them and what happened to them in the waiting room and their level of education and how much reading they did on the internet before they came in. And it's like, if you take a little bit of time, you kind of find kind of what they came in the door with, that really helps you get a better conversation with them. And communication is just so vital because it really is what builds trust, right? And you said that earlier, which is you just had to trust your, in this case, radiation oncologist's opinion that it was right for you ultimately, because the numbers didn't really make, like, they didn't add up for you,
They
right?
did not.
Right. And so like trust is communication, right? And communication is unique, right? It's like me seeing you, I'm a human being, we're having a conversation. I think so many doctors just come to the room and they're like check boxes, like, okay, we got to talk about your diagnosis, we got to talk about the treatment plan, we got to talk about side effects, here's the consent to sign, okay, these are the next steps. And they're not starting kind of from the foundational of like, like coming in the door and making sure that we're like treating each person as a whole, as human being. The second thing I would say is that there's no right answer often. Almost always there's not like a singular right answer, right? And so understanding that, I think all physicians, providers, researchers are like very type A personalities. We want to get the gold star. We want to get 100%, A++. And just realizing that what is the right, plan for this person is probably not the right plan for this person. And understanding that coming to that conclusion together, trying to figure out, again, sussing out, even if it's the small tailored things of like, what can we do to make this easier for you? It's not one size fits all. It's really, or it shouldn't be. How about that?
Yeah.
It could be, but it really isn't, because we're all, as I said, beautiful butterflies filled with white light, and each one of our lights is unique. um, and that's actually very helpful as a provider, again, to like constantly, like we're tested constantly. There is a right answer on tests. There is not a right answer for individuals, right? There's the right answer for them in their situation. But even that can change over time, right? You can have people who are willing to be so aggressive, even in the face of horrible odds. They're rooting for that 1%, right? And then later on, they're like, that chance of the illusionary cure is not worth it for me anymore. I have too many side effects. I want to go to, vacation with my family. I just need a break from this. And that's okay too, to even have that shifting, of what the right answer is. And then the last thing I'll say, that like my perspective, at least from an artist, is that that concept of kind of doing what you love, being, in this case, mission driven, is the thing that gets you out of bed in the morning, right? And like, if it doesn't get you out of bed in the morning, maybe you should slightly shift your practice so that you can get closer to your true north. And I think that would help reduce burnout, but it would also help make you a better doctor, because happier doctors are better communicators, they have better teams, and they provide better care. And this concept of burnout is like so cliche, right? It's like everywhere in the news, yada, yada, yada. But I cannot tell you how many times when I tell people that I don't work on the weekends that they are impressed.
My thesis was on burnout.
Yeah.
This was 2019, before it became front page news everywhere.
Mm-hmm.
So I've spoken to a lot of clinicians about burnout, and you're totally right. You are an exception if you're not working the weekend.
Yeah. I don't work on the weekends.
I think that's a great goal for everybody.
It's really a great, 100% every single person. In medicine, we call a weekend where you don't work a golden weekend, which is just a normal weekend. But this concept that our weekends are golden is tragic, but it's also kind of beautiful, which is like, no, this is golden. Like, this is my golden time. This is like, gold is like precious. Like, we need to use it wisely. We need to do it up every single weekend. I'm like, what are we doing? Because this is the weekend. I'm still like a teenager in that capacity. I'm like, what are we doing this weekend? It's not even half the time. I'm like, I swear I'm like on the couch, like eating ice cream, but like, that's my time to eat ice cream. So
Love it. Dr. Chino, this has been amazing. I normally try and synthesize episodes at the very end, but I'm not even going to try it. That was such a beautiful summary. And I think we're ending on a note that is, spend your weekends how you want to spend them, but also eat some ice cream, which seems really good.
That's good advice no matter where you are.
I really appreciate you coming to our podcast.
Thank you for having me.
This was phenomenal. Thank you. This episode was supported by an award from the Patient-Centered Outcomes Research Institute.